All right, it's my pleasure to talk to you all and give you an update on the FORMA spacer system. Just wait for my slides to load here. So this is currently an investigational device, and I'll show you a case of a 69-year-old woman who we treated with the FORMA device as part of the U.S. early feasibility study. She was having classic symptoms of severe TR and had had prior CABG and stage 3 chronic kidney disease, diabetes, and atrial fibrillation. And these are some of the key echo images showing her dilated tricuspid annulus, severe TR. This was before the updated grading system, but she was probably more in the massive or torrential range. And we'll move forward here. The FORMA repair system is placed via a subclavian approach, and a prepectoral incision is used, and a small pocket is created, and the delivery system advanced through the left subclavian vein. And we have 3 different device sizes. Most commonly, a 15 or 18 millimeter size device is used. And the key portion of the procedure is positioning an anchor in the interventricular groove of the right ventricle. This is the patient's 3D TE, confirming that the etiology was from annular dilatation and with a large central jet of tricuspid regurgitation. And cardiac CT is a key part of the pre-procedural evaluation. We evaluate the venous anatomy to ensure that the device can be delivered. This is particularly important in patients with pre-existing device leads. And also the right ventricular anatomy to assess the structures, the papillary muscles, the moderator band, and trabeculations, to ensure that the device will not interact negatively. And the FORMA procedure itself involves a right ventriculogram, and this is used to help guide positioning of the anchor. There's a predefined location to place the anchor in the interventricular groove based on the CT, and so we reproduce that projection in the cath lab during the procedure. And anchor positioning is one of the key portions, and you can see on the left side, this is the actual anchor going in. And we really have to confirm with TEE primarily that we have very good contact, and Becky can talk about this, how important it is to confirm really good contact between the delivery catheter and the trabeculated RV myocardium to ensure that that anchor is stable in position, but also to confirm that it's not against the free wall. So this is really the most critical portion of this procedure. After the anchor is deployed, the rail is in place, and then the spacer can be slided over that rail, and you can see the radiopaque markers on either end of the spacer. And then tension can be fine-tuned on the rail system to optimize the degree of TR reduction. So the device is a very simple concept, reducing the TR just by improving coaptation of the leaflets on the spacer. You can see the 3D TE images of the device in place. And 2D images show a reduction in the degree of regurgitation by color Doppler. And more quantitative parameters here, 3D vena contracta reduced by 1/3, so pretty significant, as did the reversal TVIs in the hepatic veins. And to go along with that, we really saw a dramatic change in the right atrial waveform as well. So whereas you had a ventricularized waveform to begin with, it looks more like what you would expect with an RA waveform, so pretty dramatic change there. This particular patient experienced significant improvements at 1 month and 6 months. You can see that her 6-minute walk distance improved sequentially, and the congestion reduced significantly, as evidenced by the BNP, the bilirubin, and the degree of edema. And the RV size and the right atrial size might have decreased slightly too. These are slightly different echo images, but there are some suggestive changes that the heart size has decreased on the right side at 6 months. And the regurgitant measures, the EROA and regurgitant volume, continue to be decreased at 6 months, as did the hepatic vein reversals by Doppler. So the early feasibility study involved 5 sites in the US, And we completed the first phase, and this data was presented by Sushil Kadali at TCT 2 years ago. And this slide really shows how important it is to take into account the degree of TR, that most of these patients in the FORMA early feasibility study had torrential TR. As you can see, all of these dots above that threshold for torrential. Despite that, there were significant reductions in the EROA, and that was sustained at 1 year, as you'll see later. Significant improvements in the NYHA class at 30 days. Most patients improved the 6-minute walk test, although there were some who didn't. You can see the red lines. And almost everyone experienced an improvement in quality of life. The 1-year data is now under review and will soon be published likely, and this is just showing that it was sustained. Those changes were sustained at 1 year. We also saw an increase in the stroke volume and cardiac output to go along with that. So here are some of the safety endpoints and adverse events, and this is really the Achilles heel right now of the FORMA system. Mortality at 30 days was 7%, and then at 1 year, 31%. But really the key two things that we've been noticing: device migration, 3 cases, 10% at 30 days, and then RV injury occurred in 2 patients requiring conversion to open surgery, and one of those patients did not survive. In the patients, however, that did not experience one of these adverse events, that was about 70% of the patients who didn't have any of these adverse events. We did see success in the device and efficacy. The second phase of the study was initiated, but we did see some anchor dislodgements, and thus the study is now paused so that the device can be changed and improved, and particularly with the anchoring mechanism. So in summary, in a patient cohort with torrential TR and severe symptoms, multiple comorbidities, the FORMA repair system was feasible, and at 30 days and 1 year, there were significant improvements in NYHA class, 6-minute walk distance, and quality of life. And improvements are needed to the anchoring mechanism, and those are underway. Thanks for your attention.